Hi, my name is Dr. Amir Garakhani. I am an attending psychiatrist and the Director of Education at Silver Hill Hospital in New Canaan, Connecticut. Thank you for joining us. I apologize for the delay. There's been some technical difficulties, but we're getting ready to get started. In a moment, I'm going to introduce Dr. Jennifer Downey, who's going to be presenting on taking a sexual history in the adult psychiatric patient. But before I do that, a couple of minor housekeeping issues. One, if you wish to ask questions during the discussion, please look for the question bubble, and you can submit your questions there, and we'll try to get to them at the end. There'll be about 20 minutes towards the end of the talk for questions. And the second thing is, at the end of the lecture, you'll be able to click on that Q&A box and go to the publish section, where there will be a survey that you can fill out to get continuing education credits. So without any further delays, let me get started by introducing Dr. Jennifer Downey, who is a clinical professor of psychiatry at Columbia and a faculty member of the Columbia University Psychoanalytic Training and Research Center, where she also teaches residents. She completed her medical school and residency at Columbia and has spent a large part of her career working on research in sexual orientation, Turner syndrome, and the mental health effects of infertility in women, and was one of the first investigators to demonstrate that sex hormones in homosexual and heterosexual women do not differ. Her most recent research has addressed sexuality in individuals with mental disorders, specifically bipolar conditions. Some of you may know that Dr. Downey worked with Dr. Richard C. Friedman, who passed away this year, and published a groundbreaking book called Sexual Orientation and Psychodynamic Psychotherapy in 2002, which was re-released or published again in 2008. She also recently published a book with Dr. Cesar Alfonso called Advances in Psychodynamic Psychiatry. She's also the interim editor of Psychodynamic Psychiatry. Before preparing talks for Grand Rounds, I asked Dr. Andrew Gerber, our president, for some names of some very interesting and potentially thought-provoking speakers and topics, and he mentioned Dr. Downey, so I was very eager to have her come and give a talk that I don't think gets enough attention in our field. So I'm very excited to have Dr. Downey here with us today. I'm going to hand it off to Dr. Downey.
Thank you. If people can't hear, please let us know, because we have had a bit of technical difficulty. I am very honored to be with you today, and I'm very delighted to talk to you about one of my favorite topics, which is sex. And in particular, the things that I'm going to be saying today I've learned these things from teaching a course at Columbia for psychiatric residents. This course I taught with Rick Friedman for 23 years. So there may even be some folks in the audience who've taken our course. That's always a possibility. In any case, what we did was we created this course for residents, and we asked each resident to take a sexual history from one of his or her patients, and then to present it to the class. And I must say that this experience of teaching this course was one of the richest experiences I've ever had in my life, because I learned so much from the residents and from their patients. And what I'd like to do today is to share with you how one goes about taking the kind of sexual history we were teaching, so that you can add it to your armamentarium, your clinical armamentarium. And I'm not going to talk much about scholarship today. I'm mainly talking about a strategy for doing an assessment with a patient. And the kind of sexual history I'm going to be talking about is not really DSM based. It is going to include the areas that DSM deals with, but those of you who've studied the DSM know that the DSM is very limited on the topic of sex. And the only topics that the DSM takes up that have to do with sex are the paraphilias, the sexual dysfunctions, and gender dysphoria. And that's it. And sex is so much more, and all of our patients have concerns and questions about their own sexuality and their own sexual history. And so that's what we're going to talk about today, which is how to elicit that so that you can use it to enrich your clinical work. And let me just say a word about how, if you have never taken the kind of sexual history that I'm going to talk about, if you've never taken one before, let me make some suggestions, because I think that the thing that would be most useful is for everybody here who hasn't taken a sexual history like this, try one. And once you've tried one, it's like your first physical exam. You've learned how to do it. It becomes part of your armamentarium. And when you need to, you can do a physical exam, or you can do a part of a physical exam. Similarly with the sexual history. Now, if you are going to take your first sexual history from a psychiatric patient, I have some suggestions for you. First of all, you have to pick a patient. You have to pick someone who can give you a history, meaning to say somebody who's not acutely agitated, say, someone who's not so severely paranoid that you couldn't ask a couple questions. And then who do you pick? Well, I would say that you pick someone who can tolerate talking to you for 45 minutes. That was how long we asked our residents to spend taking a sexual history. Obviously, you could take a much longer sexual history than that, but 45 minutes was all we asked. And I would say that you would think about, well, which patient might you pick? And it almost doesn't matter. You can pick someone who has presented to you with a sexual concern. That's a very easy and straightforward approach to take. Another very rich area from which to pick a patient is among your patients who are not doing well. Say they've had treatment, they've had quite a lot of treatment and it's been quite good, and somehow or other they are still stuck and they are not doing well. And those people are absolutely right for taking more history so that you understand them better, and oftentimes taking a sexual history will show you why the patient has not gotten better. And we'll go into some examples of that. And then, you're going to consider what psychiatric illnesses or disorders the patient has, because psychiatric disorders relate to the sexual history, and the sexual history relates to the psychiatric disorders. And if you can understand them together, you will understand the patient much better, and you'll have a much better time treating the patient. And finally, I suppose there are a few people here who are treating supervised cases. And I would say that if you're picking a patient from whom to take a sexual history and you have a supervised case, make sure that you see that check and that your supervisor is okay with it, because not all supervisors believe in asking patients direct questions. And these are going to be direct questions that have to do with sexual aspects of the patient's life. So always good to have the support of your supervisor. Okay, so we're not going to be talking about what to do with the information that you receive. We are going to be talking about making an assessment and getting information. And what you do with that information is a separate task. But luckily, because of where you work, you're surrounded by people who know a lot of things. And you can very easily, if you know what is going on with your patient, you can very easily ask someone for advice about how, therefore, to help the patient. So you don't have to know everything. It's okay if you find out something you don't know anything about. That goes with the territory. Okay, I just wanted to share this cartoon with you. This lady is reading a book, it says everything you never wanted to know about sex, but we're afraid someone would tell you. Just a few basic initial points. The initial interview must be sensitive to clinical context. And all that means is that you wouldn't sail into doing a sexual history without considering what this patient's situation is. If the patient is in the ER, the patient has just had something awful happen to them, nobody would start by taking a sexual history. You have to start with where the patient is and what the chief complaint is. You know that already. And the clinical history that we're going to be talking about should be developmental. That was one of Rick Friedman's and my biggest points in our teaching always, was that you have to consider the development of the person in order to understand them. And it's not so hard to find out about the development. You can ask. You don't have to put the patient on the couch. You don't have to wait for them to free associate. It's highly straightforward. Okay, now we're going to be talking about psychosexuality today. It's part of development. It's actually a very, very large part of development. And one thing I'd just like to set straight is adult erotic sexuality is only part of psychosexuality. So one of the things I'd like to communicate here is try not to go to adult erotic sexuality as what sex is about. Sex is about much more than that, and you'll get to adult erotic sexuality, but that's not all there is. Okay, now I'm going to just hit some high points here. We're going to go into these in more depth later, but what does psychosexuality include? People are always amazed by the things that it includes. It's so inclusive. It includes childhood sexuality and attachment relationships. And it's always good to remember that there is childhood sexuality. Freud made that point. But sometimes we modern psychiatrists and mental health professionals forget that sexuality starts very young. Gender is very an important part of psychosexuality. Gender identity, gender role behavior, and feelings about gender adequacy. We'll come back to those with some more detail. Sexual orientation. Rick and I spent 20 years writing about sexual orientation. A lot has changed during that time. I would say the science has not changed, but people's beliefs have changed about sexual orientation. Thank God, because people were very benighted about sexual orientation for a long time. Romance and sexual relationships, obviously very important. This is something your patient is going to expect to talk to you about in adolescence, in adulthood, and late adulthood. And late adulthood is good to remember because people are still sexual in their late adult years. And finally, sexual symptoms and dysfunctions are also part of psychosexuality. Now, every adult individual, and therefore every adult patient who comes to our office, is a sexual person, no matter the age, no matter whether celibate or not, no matter whether he or she has the language to discuss it. That's a very interesting challenge. Sometimes people's language to discuss sex is not the same as ours. I mentioned the celibate with a chuckle about my own self, my naive young psychiatrist self, because when I first went into private practice, I was referred a number of patients who were priests and nuns because one of my supervisors was a Jesuit. And so he referred me a lot of these folks, and I still remember the shock I experienced when I learned that these individuals in my office were sexual. They might have taken the vow of celibacy, but the vow of chastity, but that didn't mean that they didn't think about sex and in some cases that they didn't have sexual relationships. So just because someone presents to you looking as if they should have no sexual life doesn't mean that they don't, or at least that they don't think about it. So it's always good to remember. Now, the clinician picks, that clinician is you, based on clinical appropriateness, what questions about the sexual history to ask any particular patient. And that's why we're not talking about a structured interview here. I have myself done structured interviews, sex interviews with people. It's really agonizing because so many of the questions don't apply to a particular person. And when we're clinicians, we can choose what we think is most appropriate. It's a much more interesting and much more interactive process. Now, sexuality is such an important part of life. It's usually folded not only into our patients' lives, but the mental disorders we are treating them for. Think just for example, that people go through puberty. And let's say they go through puberty between the ages of 11 and 14. Obviously, some people start a lot younger than that. But the incidence of depression in young women gets much higher, same age as the onset of puberty. And if you think about that you become sexually mature, and you also at the same time become much more prone to develop a first episode of a depression, that's a good reminder of how sexuality and mental disorders can interrelate. Responsible clinicians find out how the sexuality and attachment issues of the patient are intertwined with a psychiatric disorder. Attachment issues is not going to be our main topic here, but we are definitely going to touch on it because attachment is part of sexuality a lot of times, not always, but a lot of times. And one of my major points here is we have to ask in order to find out. We cannot go based on what the patient looks like or how the patient talks, because if we do, we're going to miss the boat. Now, I'd like to talk about some of the domains of the sexual history. The first is demographics. And the reason why this was part of our course, Rick's and my course. And the main point here is for you to think about how many of these demographic things, say, affect sexual experiences. Take, for instance, the age of the patient, the gender of the patient, the marital status. Has the patient ever been married? Has the patient never been able to be married? Psychiatric disorders oftentimes prevent people from becoming able to be married. That's a very, very significant piece of data. And whether people have been able to have children or whether they were not able to have children, these things are very important. The ethnicity and country of origin of patient and the patient's parents is very important. And I'd like to combine that with mentioning religion. Religion of upbringing, key, absolutely key if you're going to be thinking about the sexuality of your patient, and also the current religion, if any. Now, we mental health professionals tend to be a kind of secular lot, and we have a tendency to think that religion is very important. We might think that, but our patients do not think that way. Our patients are affected very much by their religious beliefs. And even people, one thing that's always intrigued me a lot is that people can sit in your office and tell you that they don't believe, that they left the religion of their childhood and it has no relevance. And at the next breath, they tell you that they were raised in a strict Roman Catholic family in a strict Roman Catholic country, and that their sexual behavior as adults causes them great shame, and that they believe they will go to hell when they die. Now, the thing that's really interesting about that is that the person who's telling you that is someone who just told you they don't believe. So that's why it's so beneficial to find out something about people's religion, especially religion of upbringing, as well as culture and ethnicity. The circumstances of upbringing are important. The education and occupations of parents is important. The degree of security and comfort is very, very important. Let's not take for granted how we live. We may live comfortably in a home where there's a bedroom for every 1 or 2 people. But some of our patients, the ones who experienced poverty, for instance, in life, grew up in a home that was 1 room. And there were like maybe 6 or 8 siblings. And a lot of times the siblings shared a bed. And that affects one's sexual experiences as a child, just as it affects you if you grow up in 1 room and you are exposed to the sexuality of your parents. I'm not saying that that's a bad thing. I'm just saying that it's something for us to consider, that we should never take for granted that our patients had the same life and childhood that we did. Okay, sexual adaptation is something our patients expect to talk to us about. Current sexual relationships, degree of satisfaction, any problems they have with their partner, and the degree of attachment or intimacy. I think my most important point here is that if you ask about a current sexual relationship and the patient tells you about it, that it is desirable to ask, if at all possible, how about, do you have any other sexual relationships going on? The reason for that is not everybody is having just one sexual relationship at a time. And if you ask, most people will tell you, as long as you are asking in private and you're not asking in front of their partner. Similarly, history of past sexual relationships is very important, such things as whether they were abusive, whether they were satisfying, whether they were with appropriate people. There are lots of things to find out about people's past sexual relationships. And what I try to do, if I have the time, meaning to say anybody where I'm trying to get to know the patient, I ask for both opposite and same-sex partners. And usually, in my experience anyhow, most patients have most of their partners are either same gender or opposite gender. However, it is useful to know whether somebody, say, who's had a heterosexual life since, say, the age of 18, for example, hasn't had any homosexual partners, if they had homosexual experiences at a younger age. It's useful. It will help you understand the patient better. Now, when it comes to how one grows up in one's family, what things are important? The attitudes of parents or caregivers towards their own sexuality is very important, and patients' physical development and sexual interests, and how the family dealt with that, how the parents dealt with that. Another issue is siblings and how caregivers dealt with sexuality of patients' siblings. And sexual behavior between siblings. I think that sexual behavior between siblings is vastly underreported, vastly. It's very, very common. And, you know, we're going to come, well, I'll save my comment till we get to trauma. Anyway, patient's experience of sexual development, age of puberty, age of first menses, feelings about the body. Everybody has feelings about the body when they're growing up. Whether they ever share them with anyone, whether they ever have a chance to ask any questions is another question. But that everybody has feelings about their body. That's one of those questions you get a yes from every single person. Now, the concept of milestone is a very useful one. I don't know how many people here have ever given a Denver development test, but a Denver development test is something you use as a pediatrician, and you write down on a graph at what age the child reached certain important milestones. An example would be age when they first stand up. And the reason why that's such a valuable concept is because milestones mean that you got there, and then ordinarily what happens is you can do that. You can continue to do that. Most normally developing people do not drop back. They only move forward developmentally. So the milestone concept is useful when you consider sex. And these are the romantic milestones I've just written down. These are the ones I use. First crush, first date, this means age at, first had a boyfriend or girlfriend, first fell in love, first married or established a committed relationship. And I try to ask for opposite and same-sex partners. Usually people have an extensive history with one kind of partner and not that much history with the other kind of partner. Let's just think for a moment about something like first fell in love. First fell in love is one of my favorite questions. The reason why I like it so much is that falling in love can be difficult. And I have met men age 50 who have never fallen in love. I have met men age 65 who have never fallen in love. And if someone tells you they've never fallen in love, it's something to think about as you try to understand what makes them tick and what their issues are, because people who have never fallen in love can feel very, very disappointed in life. It's an important landmark. Okay, going on from romantic milestones, we get to sexual milestones. Age of first holding hands, kissing on the mouth, fondling or oral sex, penetrative sex. Obviously, we don't use that word penetrative with most of our patients because they would think we were weird. And masturbation to orgasm. And again, for opposite and same-sex partners. Now, I can't emphasize enough how useful these questions are, because they are so cut and dried and they're so kind of medical. And that can be good if you're trying to sort of understand where somebody's coming from. And let's take an example of kissing on the mouth. I'm reminded of a trainee of mine from years back who asked his patient, who was in the hospital and not doing well. Okay, she had a lot of good treatment. She was doing lousy. And he asked her, he figured, well, I'll take a sexual history from her. I have to do it anyway. It's a part of my course. I have to get credit for the course, so I have to take the history. So he picked her. And he says, so how old were you when you first kissed on the mouth? And he's like going down his list of the things he wants to ask. And she says, well, that would be when I was about 7. And that would have been with my father. And what then happened was that question opened up a history of incest with this patient and her father that lasted for decades. And she was then in her early 20s, and she was in a great psychiatric hospital, and no one had ever found that out. So if you don't ask, you don't find stuff out. In this case, it turned out to be, it really opened up his case, and after that, it was possible to treat her so that she got better. Now, sexual orientation is, as I said, Rick and I have written whole books about this, but there is no official definition of sexual orientation. If you look in the textbooks, you won't find it. This is how we define it. We define it with 4 different aspects: sexual activity, sexual fantasy, self-identity, and social role. And those, just to make life complicated, these are not always congruent. For instance, a person could have had only sexual activity with an opposite sex partner, but he or she has sexual fantasy that is mainly about a same-sex partner. And if you have such a person in your practice, you have a person who has a problem. That person has a problem because there is an incongruence between how they're feeling and how they're acting. And they're going to have to solve that problem. And if you're their therapist, or you're their psychiatrist, or you're their social worker, you could be involved in helping them work out that problem and figure out where they fit in life and what kind of sexual orientation they have. Self-identity refers to the inner belief that of what you are, whether you're gay, whether you're straight. And social role has to do with how you present yourself. There are a lot of folks who have never come out. They may know that they're gay, but who have they come out to? Sometimes people only come out to their friends, and their families do not know. If that's the case, that can be a problem. What do you do on the holidays? What do you do with your boyfriend or your girlfriend? Your family doesn't know that you're gay. This is a potential problem for patients, but also something that you can work on if you're working clinically with somebody. Gender. Well, gender is a very hot topic right now, and I'm not going to go into a great deal of detail. But gender identity, keep in mind that gender identity, or the sense as to whether you're male or female, that was kind of the old-time definition. It used to be felt that this was a category. You were either male or female, and that this was usually settled by the time you were about 18 months or so. Then it started to be observed that some people had gender dysphoria. They felt that their true gender did not fit with their assigned sex at birth. And that's where that expression comes from: a man in a woman's body, or a woman in a man's body. There are people who feel that they are the wrong gender, and they need to change that. There are also, it turns out, this is something that's become more of an issue lately, people become more aware of it. There are people who feel they are non-binary. There are a lot of expressions for that. One is genderqueer. They have characteristics of both genders. I have some of these folks in my practice, and among the ones that I have in my practice are people who have been in a stable, this has been their stable identity, which is non-binary, for many years. They don't seek to have surgery. They don't seek to change their gender. They feel they are somewhere in the middle. Negotiating that with people who are ordinary folks who don't understand what genderqueer means can be challenging. And that may turn up as an issue if you are working with a patient. Gender role just has to do with how you present yourself, whether male or female, whether some people, if you think of other degrees of this, you know, if you think of, say, beauty contestants, female beauty contestants, those young women tend to be very, very far over on the femininity side. I don't mean to say that they are deeply feminine. I'm just saying that they present themselves as deeply feminine. Gender self-esteem is another issue that Rick and I think is important, thought was important. Gender self-esteem has to do with whether you feel you are successful as a male or a female. And you know, a very common example is boys who are not athletic. And if you are not athletic as a boy, especially in certain environments, and you have a gentle nature, say, and you are not one who is a fighter, such a boy can feel very inadequate in his gender without being in the least abnormal. So that it's good to realize that people live in their culture, and their culture may be quite have imposed expectations that are unrealistic. Not every boy is athletic, and you should be able to be feel a successful boy without being great at, say, football. Still, it's a source of a lot of suffering for young people, something to think of. Among the domains of sexual history is trauma, and naturally there are many kinds of trauma, which we won't go into here, but I've divided them here as physical abuse and neglect, and there's also sexual abuse, boundary violations, and non-consensual sex. When I talk to people about sexual trauma, I usually ask about experiences they had before age 16 and experiences after. The only reason for that is to try to understand whether they had childhood sexual trauma. I tend not to use the word abuse because I think most people who have experienced trauma do not call it abuse in their minds unless they have been in therapy and their therapist used, or say the legal system or something like that, used the term abuse. So I tried myself to avoid the word abuse. And I'll ask something like, did you ever have any experiences before you were 16 that were sexual that disturbed you or that you didn't want to have happen? I'll use an expression like that. Other trauma, naturally, all kinds of trauma can affect people's development. Homelessness would be an example. A loss of a parent at a young age can be very devastating and affects people, their psychosexual development. All right, now coming to some special issues to consider that may or may not apply to your patient. Reproductive, well, let's come to safe sex first. A lot of us ask about safe sex. I have learned that asking about safe sex, you nearly always get, oh yes, doctor, I practice safe sex. But I have learned to never take that at face value. The next thing to ask is, oh, what do you consider to be safe? And I'm reminded of someone who was a patient of mine years ago, who was a health professional, who told me that he only engaged in safe sex. And for about 3 months, I felt I didn't have to worry about him. And then I found out what his definition of safe sex was, which was that he had sex with only one partner. However, his partner was having sex with a lot of different partners, and they didn't use protection, meaning to say my patient and his partner did not use protection. So my patient, who was very sophisticated, still referred to, thought of himself as practicing safe sex, although his sexuality was completely unsafe. And I would say in his case, there are people who are naive. In the case of my patient, not naive. He was filled with denial. So if you ask about safe sex and you learn about the patient's sex practices, you will find out it's a great public health issue. Reproductive events are very important. You know, say whether a young woman has ever had a pregnancy. Very, very valuable to know whether she's ever given birth, what happened to the baby. Those things are very important. And sexual dysfunctions. Sexual dysfunctions takes us back to the DSM, and the sexual dysfunctions include disorders of desire, disorders of inability to have an orgasm, and pain disorders. And all I can say about this is they are very, very common. They are important, but it behooves us as mental health professionals not to define sexual health based on sexual dysfunctions, because there's a lot more to sex than sexual dysfunctions. Other special issues: impulsive and compulsive sexual behaviors. We tend to think of this as something that men engage in more than women, but there are a lot of women in our patient populations who engage in sex with unknown partners. That's very dangerous, and it is usually an enactment of some kind, and that is impulsive and compulsive, even though they're not men. And you know, porn addiction is something, first of all, there's controversy, I would say, over whether addiction applies to pornography. But whether it does or whether it doesn't, if you are being told that someone has a porn addiction, you have to find out what that means, because that's an expression in the lay terminology, but it doesn't mean the same thing to everybody. And you have to find out what it means and how disruptive it is to the patient and to the patient's family. I'm reminded of somebody in my practice whose husband watched porn with the door open. And one of the things that had to happen was that he had to and these people were long married, they had an important relationship. Whether he watched porn or not was not really the issue. She didn't want the door open. So they were able to work that out, but it started out as a problem. And paraphilias are a special issue, and most of us do not treat paraphilias. Treating paraphilias is a specialty in psychiatry. And my thought here is just that we shouldn't be afraid to ask about paraphilias. Even if we don't know how to treat them, that's okay. You can always ask someone what to do next. But it's important to know whether the patient engages in paraphilias. A lot of times, if they have been involved with the legal system. I'm reminded of somebody years ago who I asked what was the most illegal thing he had ever done sexually. I was looking for that for a paraphilia answer, and he said, I had sex with my girlfriend on the Long Island Railroad, i.e., he was not engaging in paraphilias. He was just telling me. what his life was like. And finally, other special issues, difficulties secondary to age and illness, menopause. Menopause causes many women to feel unattractive. It can cause you to have painful intercourse because of estrogen deficiency, and that can cause partner problems. So it's a good thing to find out about. Medical illnesses like diabetes and heart disease affect people's sexual performance and their feelings as to whether it's safe to have sex. Surgeries on sexual parts of the body, this affects both men and women. And if we've never had ourselves this kind of surgery, it's hard to imagine how devastating it can be to, for instance, women who have breast cancer, who have their breasts removed. That can be very devastating to their feelings of being sexually whole, and they may lose interest in sex. So it's something to consider. And side effects of medications. Hopefully everybody here talks to patients about possible sexual side effects of medications. My thought about this is that if we don't talk to our patients about sexual side effects, our patients, and we don't offer them a chance to tell us, our patients will quit the medicine. And because patients don't like to, some people can tolerate having sexual symptoms that other people can't. And if you have such a patient who can't tolerate having sexual symptoms, you need to know so you can decide what to do next. Sexual fantasies is one of my favorite areas. And we're not going to talk about that at length today because it's super complicated. But let me just say a couple things to point people in the right direction. First of all, what we're talking about in a sexual history is conscious erotic fantasies. So you don't have to have, no one has latent homosexuality, no one has unconscious sexual fantasies that you have to find out. No. All you need to find out is people's conscious fantasies. And a lot of times what I ask, sometimes I ask what kind of pornography people like to watch, but I'm also interested in what kind of attractions they have on the street, because an attraction is a fantasy. And it's an easy thing for people to talk about. It's hard to talk about sexual fantasies for some people, but it's easy to talk about attractions. Romantic fantasies is here because women present some challenges when you take the sexual history. For one thing, not all women are aware of having erotic fantasies. And although they don't have conscious erotic fantasies that they can talk to you about, a lot of them have romantic fantasies. And romantic fantasies in some women serve the same purpose as conscious erotic fantasies in men. There is no man, in my view, who has no erotic fantasies. Maybe there's a man somewhere who has no testosterone because he's, lost his source of testosterone, doesn't take any. Maybe he doesn't have any erotic fantasies. But generally speaking, all men know their erotic fantasies, but women don't necessarily. And if you have such a woman in your practice and you're trying to understand her better, ask her about her romantic fantasies, because a lot of times those serve as erotic fantasies for her, and they cause her to feel excited sexually. Oh, I'm going to skip this vignette, I think. And I'm going to present another vignette if we have time. Let's see if I can find it quickly. Okay. This is the only vignette we're going to talk about today, so we're not going to spend a long time on vignettes. This is called The College Freshman with Suicidal Thoughts. T is a freshman student who comes to the student health clinic. You are told by the intake nurse that she has suicidal thoughts. You think, Did she come to college depressed? And did she stop her antidepressants? You call T into your office where she looks at the floor. Without meeting your eyes, she tells you this story. Lately, I've been feeling really ashamed of myself. What would my parents say? I came here to be a chemistry major. I have a scholarship and I'm not studying that much. I've gotten into a relationship with my roommate. We had sex. I liked it. Now I can't stop thinking about it. I have a residential advisor who is gay, and I told her. She said I should come out as gay, that I'd be happier that way. Since she said that, I've felt terrible. How can I ever tell my parents? They would be devastated. Besides, I really like this boy in my bio class, and also I still feel I'm in love with my high school boyfriend. In fact, he's coming to visit this weekend, and I really want to see him. Ever since the RA said that thing about coming out, I've been really scared and wondering if I don't deserve to be here. I am taking up a place for a good person. The school thought I was a good person. I'm not. What you ask at this point? Is she thinking of ending her life? No. The answer is no. Does she feel that if something was about to kill her, she would want to avoid it? Yes, she would want to avoid it. When did she start to feel so bad? She felt okay, even though confused about her feelings for her roommate. These feelings of dread and shame started after the RA said she should come out. Until then, she felt excited about college. She was able to concentrate on studying, and she had joined the intramural soccer team. You take a brief sexual history and you learn she has always been attracted to boys, except for a crush on a girl she had in grade school, and a single kissing episode she had with a girl at age 13. So that takes us back to the milestones we were talking about earlier. She has been sexually active with boys since age 16, and she has enjoyed that. In high school, she was in love with her boyfriend and was with him for a year when they graduated and went to different colleges. So that's our vignette. And why did I want to share that vignette with you? I wanted to share with you that taking a sexual history is a very simple vignette. But what happened to this young woman was she was, in her life, she was perturbed. And she was perturbed by the comment of her RA telling her that she's gay and that she should come out. That was incorrect. The RA was wrong, and the patient should not come out. The patient should live her life and have a chance to figure herself out. And hopefully, this young woman goes to a college where she can get some short-term psychotherapy, because this isn't a long-term problem. It's a short-term problem, but it presented very acutely, and therefore came to the attention of the college psychiatrist. Okay, so this brings me close to the end of my talk. I think it's taking the time to ask about the sexual thoughts, feelings, and experiences of our patients gives us more therapeutic power as clinicians. You're going to know your patient better, and you're going to understand your patient better. That's always a plus, as long as you have a chance to work with the patient. And even if you don't have a chance to work with the patient, it helps you to refer the patient appropriately if you understand the patient better. A couple of references that might be useful. Rick and I wrote an article about taking a sexual history on the adult psychiatric patient. It's really has this information in it. So if you have this talk on your website, you don't need our article. We also wrote an article on sexual fantasies in men and women that has turned out to be our most famous article. And that was reprinted in Sexual Orientation and Psychodynamic Psychotherapy, which came out in 2008. The article, interestingly, fascinatingly to me, this article came out in 2001. Rick and I didn't give it a second thought at the time, but 100 people a week on ResearchGate read this article. All I can say is it a good article? Yeah, I think it is. But I don't think many people are writing about sexual fantasies, or else why would so many people be reading our article 20 years later? That's crazy. Okay, so this brings me to the end of my presentation. I look forward very much to questions, and thank you so much for inviting me to talk with you. I've reached an end here.
I was muted. Sorry about that. Thank you so much, Dr. Downey. I really appreciate your talk. And we're still waiting on some more questions, but we have one question. Someone asked, how do you feel about folks that pathologize a sexual identity?
Well, I love that question because a lot of people still do that. And I am happy to say that, you know, mental health professionals used to pathologize a sexual identity. And I'm happy to say that that is mostly stopped. Most psychiatrists and most mental health workers do not pathologize minority sexual orientations, for instance. However, there are still a lot of people who do pathologize sexual identities, and those people are in our culture, and especially in our patients' families, and culture and families. And I think that right now in our country, we have a very polarized attitude toward sexual identities and minority sexual identities, which is highly problematic. And we as mental health professionals, generally speaking, what I end up taking on is I end up with a lot of the parents of the young people with the minority sexual identities. And I think that I end up with them because I am an establishment psychiatrist and I am straight. They think I'm straight. And it gives me a chance to help out the young people by helping the parents. Now, do I see a specific group of the parents? I absolutely do. Anybody who is willing to work on their relationship with their child or their young adult child by coming to see a psychiatrist is somebody who's very motivated to get along with their child and learn and become more tolerant. But I think it continues to be a major issue, and I think also there are people, you know, our patients do not all belong to liberal religions, and say Orthodox religions are very intolerant of sexual minorities, and that's a big issue for our patients if they want to stay in their culture. So that I would call that an unsolved problem, which we're all going to meet if we treat people of sexual minority status, and we have to do our best. Some people will be activists. I myself am not an activist, except as an intellectual. I have felt sometimes as an activist when people screamed at me when I gave talks and when I got hate mail. So even a professor at Columbia gets hate mail for saying the kind of things that I've said in the past, which were essentially that having a minority sexual orientation does not mean that you're mentally ill. that used to elicit hate mail. So there's more work to be done on this issue. Do we have another question? I can't hear you.
I'm going to keep myself unmuted. One of the questions that was actually a follow-up to that was, how do you deal with non-binary young adults who are struggling with coming out? I think you kind of answered that, which is it's a struggle. But I have a follow-up question, which is, how strong do you think the influences of peers on sexual identity?
I love that question, because I think that there is enormous effect of sexual identity. And I think that, you know, it's been in the literature for quite a long time, even though we hear more about it now. For instance, in the old days, there was the expression lesbians until graduation. And lesbians until graduation referred to young women who were at schools where they encountered other young women who were against the sort of the male dominance. You know, they were like feminists, and they, for reasons, political reasons, they became active as lesbians. And some of our patients became temporary lesbians. And some of those folks went on to become lesbians, but some of them didn't. And the reason for that had to do with, I think, with the peer environment. So I do think that peer environment can cause people to become more aware of their sexual identity. And sometimes people have temporary periods of time when their sexual identity changes. So I think that the question about whether peer identification and peer exposure affects one's sexual identity, we have to consider the youth, the youth of our patients who are affected by their environment. Teenagers, say, high school students and college students. Yes, they are. It's part of learning and growing up. And my view is that people should have a chance to experiment, and those of us who are taking care of them should educate them about the things that they want to know, and keep an open mind about what's going to happen with them, because sometimes they are in transition and it is not clear yet where they are going to land. So it's a fascinating topic.
Yes, it is, and I've encountered that in my personal life, but also my professional life, where I've had family members, patients, colleagues say things about how they wouldn't want to send their children to all boys or all girls schools because there's a concern about their sexuality being affected by that. I have a question about sexual trauma, and the question is, how do you manage colleagues who attempt to state that sexual trauma is directly linked to an influence on sexual orientation? For instance, that sexual abuse leads to someone becoming homosexual, for instance.
Well, what I do with my colleagues who say that is I refer them to the literature, because there is quite a lot of literature, which is a little older. It's not brand new, but that's okay. It's out there. And it demonstrates that there is not an increased incidence of minority sexual orientation in people who have experienced sexual trauma. However, I would like to add an additional thought, and that has to do with women who have been sexually abused by men. I've never read this written, but it is my personal impression that there are some women who've been raped by men or abused by men sexually who have the option. Some people, after all, are bisexual, and women have more tendency to be bisexual than men. And if you are one of those women who had, for instance, a period of sexual abuse from a brother or from a father or something like that, and you have any ability to be aroused by women, being able to have a relationship with a woman can be a sort of a safe haven, because some of those women who've been abused by men are really afraid of men. And most women do not have as an option the bisexual option, because they're not bisexual. Most women are not bisexual. But for those women who are bisexual, it is a comfort to have the alternative of choosing a female partner. I love your questions.
Thank you. Yeah, there's some really good questions we have coming in. I actually have a question about taking a sexual history as a male psychiatrist with a female patient. I had a situation, I could say, with we had a psychiatrist that sent a patient to us, and when I referred the patient back to him, I had started her on an antidepressant while she was at our facility, and the psychiatrist was taking a history from the patient when she returned home to New York City. It was asking her about her sexual function and trying to take a sexual history, and the patient got very angry about those questions and fired the psychiatrist and called us and said, "Can you send me to a different doctor? I don't like this doctor anymore." And I'm just curious about how, as a male psychiatrist, sometimes navigating questions about a sexual history with a female patient can give the appearance of that you're crossing some sort of boundaries. Obviously, if it's done in a clinically appropriate way, but I just want to know if this has ever become an issue with male psychiatrists with female patients.
So, let me come back to that in a moment. Let me just ask you.
Sorry, I have some trouble hearing you. So.
Can you hear me better now? I'm a
little bit better.
Okay.
Yes.
Let me ask you first. In the case of your patient that you referred to the doctor, did you have any sexual history from her in the hospital?
I did not.
You didn't?
No. Yeah.
Right. So let's say that that I'd call that an unknown situation. You don't know whether the patient had sensitivity to being interviewed about sex, or whether your colleague, while excellent, was awkward in this area. And I do think that when I teach people, I believe that men and women should be able to take sex histories from men and women. However, there are instances where it turns out that one gender is the better than the other. And I'm reminded of someone who was a student of mine who her patient was a young Orthodox man who was having trouble getting married. And he was in treatment with her for CBT obsessions. And he had severe OCD. And she was very beautiful. This therapist was very beautiful. And he developed a very hot erotic transference to her. And finally, he confessed that he thought always about marrying her. He wanted to marry her and forget about the CBT. And in that case, that patient had to be referred to a man, or referred to another kind of therapist, shall I say. It wasn't because she was doing anything wrong. It was because she had to do CBT. She was required by her residency to do CBT. And you can't do CBT with someone who is having a hot erotic transference to you. You would need to be using a different kind of treatment. So in that case, for practical reasons, he had to be referred. Usually, in all the years that Rick and I gave our course to every single resident who came through the program, nobody ever had that problem. So I think that it doesn't happen as often as you might think, but I do think that if one is learning how to do this work, one should pick easy patients because you need practice. You might as well pick an easy patient. Say, pick an older patient, for example, because you need the practice and eventually you will become at ease with asking everybody. And in my own experience, of course, I have the advantage of being a woman, so people perhaps think of me as less of a predator, I don't know. But in my own experience, the only people I've had trouble interviewing about sex, sexual history, is women who have not experienced a normal puberty and therefore are not really psychosexually adult. And so they are in a fog as to their sexual feelings. They're hard to interview. But other than that, I haven't run into that problem, and my residents have not complained of that problem. I still think, I do understand that some, this is a training issue, and some of us are not all that tactful. We have to develop tact about this topic. Tact comes from practice.
Yes. Well, I've encountered situations, as you said, where I had male patients of all ages who declined to work with female therapists or psychiatrists because they were uncomfortable talking about sexual dysfunction. In fact, I have one right now who I can only send him to a male therapist because he doesn't want to work with women because he has a lot of issues around sexual dysfunction, and he feels uncomfortable talking about that with a female therapist. So, but that actually brings me to the last question I think we have time for, which is someone asked about a client that struggles with retarded ejaculation with no medical issues and feels a lot of shame and fear. And I guess he's asking, or he or she's asking about what are some of the key issues and dynamics behind this. I don't know if that's an area that you have experience in, or.
Well, I think that's a very, very interesting question, because I think that my impression is that people with retarded ejaculation are very hard to treat. Meaning to say, not that people can always be treated, but it can be hard to help them get over that symptom. And I do think my impression is so far with this is that people have retarded ejaculation because they are anxious and because they are afraid of something that will happen. This is my own personal view. I'm not quoting the literature. So if I had such a patient, I would get him to talk to me about his relationships with his partners and what worries him, what he's afraid of. But thank you for that wonderful question. That's a great question.
Thank you so much, Dr. Downey. I really appreciate you coming on and speaking with us today. I think this was a really thought-provoking discussion, and I definitely want to get a copy of the book and read over it. And I think we can all learn a lot about taking a good sexual history from patients. So thank you so much for your wonderful talk. I want to let everybody know you can go to the published under Q&A, the published section, and click on that and then fill out the evaluation for today's talks. You can get CME credits. Thank you so much.
Thank you. Thanks so much for this wonderful.
Thank you.